71-year-old Margaret Chen, a retired school librarian from Columbus, Ohio, had strictly followed her daily routine of taking lisinopril every single morning for 6 years. On paper, her cardiovascular health seemed flawless, much to her physician's satisfaction. Yet, Margaret's daily reality told a completely different story. Every day by midday, a wave of lightheadedness would wash over her, followed by absolute exhaustion by 2 p.m. She could barely read a single chapter of a book without drifting off to sleep. Resigned to her circumstances, she told her daughter that she was simply feeling the inevitable effects of aging. Her daughter, however, refused to accept this explanation and demanded a second opinion. When a new physician evaluated Margaret's medical history, her diagnosis remained identical, but her pharmaceutical regimen was completely overhauled. The revelations that followed caught both of them off guard, uncovering a reality that holds critical importance for millions of households. If you or a family member relies on blood pressure medications like Amlodipine, Losartan, or Lisinopril, the insights ahead could fundamentally reshape how you manage your cardiovascular health. Over decades of providing medical care to older individuals, a vital truth becomes clear. While these three specific drugs are undeniable lifesavers, the standard approach to prescribing, dosing, and evaluating them in patients over the age of 65 is frequently incomplete. Far too often, the adverse effects experienced by senior patients are casually brushed aside as normal aging, when they are actually direct warning signs from the body's reaction to the medication itself. Today, we will uncover 6 critical insights regarding these prescriptions that most patients are never told. It is vital to consider every single one of these points, because the third item on our list is a widespread side effect that millions mistakenly blame on growing older, rather than on their daily pill. Furthermore, our fifth point exposes how a blood pressure reading that looks absolutely perfect on a clinic monitor can actually land an unsuspecting patient in an emergency room. If you or someone you care about manages hypertension pharmaceutically, taking charge of this information right now can entirely transform the dynamic of your upcoming medical appointments. Before diving into the specific details, it helps to understand a foundational concept called the dose assumption trap. This pitfall rests on 3 distinct pillars. First, physicians routinely select drug dosages based on standardized clinical guidelines. While this is standard medical practice, patients rarely realize that these benchmarks were established using data from clinical trials composed mostly of individuals in their 50s and 60s. They simply were not designed for an 80-year-old patient managing multiple chronic conditions with a metabolism that handles pharmaceuticals far differently than it did 20 years prior. The second pillar reveals that the exact dosage required to hit an ideal target on a medical chart may simultaneously trigger quiet, debilitating symptoms. Everyday struggles like persistent fatigue, frequent dizziness, cognitive fog, and lower limb swelling are not mandatory parts of growing older. They are frequently adverse drug reactions hiding in plain sight. Finally, the third pillar reminds us that a well-controlled number on a digital printout does not automatically translate to physical well-being. A reading deemed ideal by a clinic computer can actively degrade your daily quality of life. This is the heart of the trap. Because the baseline metrics look acceptable, healthcare providers assume the therapy is flawless, completely bypassing the question of how the patient actually feels. Keep this framework in mind as we evaluate our list. First, we must recognize that we are dealing with 3 entirely distinct types of medication, each operating through a completely unique physiological path. Consider 68-year-old Robert Morales, a retired truck driver living in San Antonio, Texas. When a routine physical revealed elevated blood pressure, his physician handed him an amlodipine prescription, with instructions to take it once daily. When Robert inquired about the drug's function, the doctor offered a brief, generic response. It lowers blood pressure. That concluded the interaction. For 2 full years, Robert took the medication faithfully, without a single clue as to how it interacted with his cardiovascular system, a gap in understanding that ultimately placed his health in jeopardy. What Robert was never taught is that these therapies alter human physiology in fundamentally different ways. Amlodipine belongs to a category called calcium channel blockers, which relax the muscular walls of the arteries, expanding the pathways so blood travels under significantly less tension. Losartan, conversely, is an angiotensin receptor blocker, or ARB, which functions by preventing a specific hormone from signaling the vasculature to constrict. Lisinopril operates as an ACE inhibitor, stopping the body from manufacturing the very enzyme required to create that tightening hormone in the first place. This distinction is vital because each individual drug class carries its own specific portfolio of side effects, chemical interactions, and long-term risks that become far more pronounced as the body ages. Identifying your specific medication category is a matter of basic safety. At your next consultation, explicitly ask your provider why they selected your specific drug class over the alternative options. If the explanation lacks specificity, it is an essential conversation to pursue. As we examine these specific drug profiles, we find that certain side effects can become highly disruptive, starting with a reality that is frequently downplayed. This brings us to our second point, the physical complication that healthcare providers often call routine, but which is actually a major red flag. 73-year-old Linda Hargrove, a retired postal worker from Richmond, Virginia, took amlodipine for 4 years, and for nearly that entire duration, her lower legs and ankles remained severely swollen. The puffiness was so pronounced that she had to completely abandon her normal footwear. Though she raised the issue during multiple medical checkups, she was repeatedly told it was a standard, benign reaction that required no worry. Linda trusted this guidance and modified her lifestyle, buying wider shoes and elevating her legs every evening. She simply endured the discomfort until the swelling escalated so severely that her family rushed her to an urgent care clinic. There, providers discovered that the fluid accumulation had spent over a year masking a serious circulatory issue that had gone completely unmonitored. This scenario plays out far more often than people realize. Clinical data from major cardiovascular journals indicates that amlodipine-induced peripheral edema impacts up to 10% of users, with risk factors climbing sharply alongside advanced age and elevated dosages. While often dismissed as a mere cosmetic annoyance in clinical settings, the physiological cause makes it a genuine medical concern. Calcium channel blockers excel at dilating arteries, but they fail to expand veins at an equal rate. This hemodynamic mismatch forces fluid to seep out of tiny capillaries and pool into surrounding tissue. While younger bodies easily adapt to this fluid shift, older adults often suffer from compromised venous return, triggering a dangerous domino effect. The swelling actively reduces physical mobility, which worsens circulatory health, ultimately increasing the immediate risk of an accidental fall. If you are experiencing lower limb swelling from your regimen, do not passively live with it. Demand a thorough evaluation of your options, which might include lowering the dose, switching to an ARB, or utilizing low-dose combinations of differing drug classes to eliminate the issue entirely. While amlodipine presents clear circulatory challenges, it is certainly not the only medication carrying hidden complications. For individuals utilizing lisinopril, our third point will likely sound incredibly familiar: a persistent, unyielding cough, and the underlying reason it develops. 69-year-old James Whitfield, a retired electrician from Knoxville, Tennessee, developed an irritating, dry cough roughly 3 months after starting lisinopril. It bore no resemblance to a standard cold or seasonal allergies. It began as a faint tickle in his throat and matured into a chronic cough that simply would not break. He consulted respiratory specialists, underwent multiple chest radiographs, and spent sleepless nights terrified that he was facing a severe pulmonary disease. Yet, throughout 8 months of medical appointments, not a single practitioner thought to ask what daily pills he was taking. This specific adverse event is surprisingly widespread, affecting up to 15% of individuals on an ACE inhibitor, with some epidemiological data pointing to even higher rates. Research highlights the specific biochemical mechanism at play. Lisinopril actively stops the body from breaking down a naturally occurring peptide called bradykinin. As bradykinin builds up within the respiratory tract, it chronically irritates the delicate tissues, triggering a dry, hacking cough that completely resists standard over-the-counter cough syrups. For an older adult, this isn't just a minor nuisance. It shatters healthy sleep cycles, induces sudden bouts of lightheadedness during coughing fits, increases fall risks, and severely erodes overall well-being. If a mysterious cough emerges after you begin an ACE inhibitor, contact your clinic right away. Transitioning to an ARB like Losartan typically resolves the issue completely and rapidly, offering a straightforward solution to a problem no one should have to tolerate. Given those respiratory risks, Losartan might initially seem like an entirely safe alternative. However, our fourth point highlights a hidden metabolic threat that requires careful monitoring, specifically for those utilizing an ARB. Rather than looking at a single patient case, the broader hospital admission data tells an incredibly sobering story. Both ARBs and ACE inhibitors share a well-documented physiological side effect that is routinely overlooked during standard checkups: their tendency to elevate systemic potassium concentrations, a clinical state known as hyperkalemia. Nephrology research reveals that hospitalizations driven by hyperkalemia among senior patients on these regimens are remarkably frequent and trending upward. The underlying cause tracks straight back to hormones. These medications suppress a hormone called aldosterone, which normally commands the kidneys to excrete excess potassium. When aldosterone levels drop, the kidneys hold on to that potassium instead. Now, layer that mechanism onto the natural realities of aging, where baseline renal function progressively slows down, leaving the kidneys far less capable of filtering out excess minerals. Combine that with a diet rich in heart-healthy staples like bananas, leafy greens, potatoes, and legumes, or the routine use of over-the-counter potassium supplements and salt substitutes. The mineral levels can quietly climb to dangerous levels. The truly frightening reality of hyperkalemia is that it typically produces zero outward symptoms, right up until it causes a sudden, life-threatening cardiac arrhythmia. To stay safe, anyone taking Losartan or Lisinopril must ensure their blood potassium levels and overall kidney performance are biochemically evaluated at least every 6 months. This basic lab work is a critical safety measure that far too many patients miss out on. At your next laboratory review, explicitly ask when your potassium levels were last measured. If your care team cannot provide a definitive date and you have been on these medications for a year without a blood draw, it indicates a critical gap in your preventive care. This brings us to the single most concerning scenario encountered in clinical practice, a phenomenon that receives far too little public discussion. Our fifth point focuses on the blood pressure reading that appears pristine on a medical chart, but actually exposes a vulnerable patient to severe injury because the medication is driving the numbers too low. Take 76-year-old Dorothy Flanagan, a retired teacher's assistant from Scranton, Pennsylvania. Her blood pressure sat at what her care team termed a flawless target, 118/70. Year after year, her physician praised the numbers, and Dorothy felt reassured. However, Dorothy began experiencing sudden falls. She went down twice in her kitchen and collapsed once on her concrete driveway, badly scraping her hands as she fell. The situation peaked when her daughter discovered her collapsed on the bathroom floor one morning. Dorothy had simply stood up, experienced a total blackout, and fallen directly to the ground. The emergency room staff diagnosed her with orthostatic hypotension, a sudden, sharp drop in blood pressure that occurred the moment she shifted to an upright position. The exact medication designed to shield her cardiovascular system was directly endangering her neurological and skeletal safety. The clinical data supporting this risk is robust. Detailed reviews of major hypertensive trials, alongside recent studies in prominent medical journals, confirm that aggressive blood pressure reduction in patients over the age of 75, specifically targeting a systolic number below 120, correlates with a sharp rise in fainting spells, accidental falls, sudden kidney injuries, and severe electrolyte imbalances. Because of this, leading medical associations now advocate for more moderated, relaxed targets for older individuals managing multiple conditions, noting that a systolic baseline closer to 140 or 150 can often be significantly safer. Consider the physical chain reaction, because visualizing this trajectory is absolutely vital. A medication lowers systemic blood pressure with intense efficiency. The moment you rise from a chair or leave your bed, gravity pulls blood toward your lower extremities because your aging blood vessels cannot contract rapidly enough to counteract the movement. Blood flow to the brain drops instantly, causing dizziness, blurred vision, and confusion. You reach out to stabilize yourself, lose your footing, and fall, frequently resulting in a broken hip. That fracture necessitates emergency surgery, followed by a prolonged hospital stay where exposure to secondary infections is common. The resulting immobility leads to rapid muscle wasting, cognitive confusion, and severe depression. An entire cascade of life-altering trauma can be sparked by a single, highly praised number on a medical chart. To protect yourself, always request that your medical provider measure your blood pressure while you are standing, not just while you are seated. Insist on checking these positional vital signs at every single checkup, and have a transparent conversation about whether your current metrics align safely with your age, your personal fall history, and your daily lifestyle. Pushing your numbers down to a youthful standard is frequently far more hazardous than maintaining a slightly elevated, stable baseline. The absolute lowest number is rarely the safest choice. To bring all of these insights together, you need a practical tool you can easily take into your next consultation. This brings us to our sixth and final point, the blood pressure medication checkup, built around 5 essential questions to ask your doctor. Write these down or print them out so they are ready for your next appointment. First, clarify exactly why you were placed on your current specific medication rather than an alternative class. You have every right to know why Amlodipine was chosen over Losartan, or why Lisinopril was preferred over an ARB, and the answer should center on your personal physiology rather than generic clinic habits. Second, find out what your blood pressure looks like when you are standing up versus when you are sitting down. Relying solely on seated readings leaves you blind to half the clinical reality, and uncovering the full picture can actively prevent a catastrophic fall. Third, verify the exact date your potassium levels and kidney filtration rates were last biochemically evaluated. If you are taking an ACE inhibitor or an ARB without routine lab tracking, that operational gap needs to be corrected immediately. Fourth, ask directly if your current blood pressure target is truly appropriate for your age and your overall physical health. The ideal target for a middle-aged individual is rarely the right fit for someone in their late 70s. This query opens up a nuanced, collaborative dialogue that doctors highly respect but rarely have the time to initiate themselves. Finally, find out if any of your other prescriptions, over-the-counter drugs, or daily supplements are secretly interacting with your blood pressure regimen. These therapies do not operate in a vacuum. Common anti-inflammatory pain relievers, specific antidepressants, mineral supplements, and over-the-counter decongestants can all drastically suppress or dangerously amplify your medication's effects. Any healthcare provider dedicated to your long-term well-being will appreciate these questions and value your active participation. If a practitioner completely dismisses these concerns, that reaction tells you everything you need to know about whether that specific medical relationship is truly protecting your health. Returning to Margaret Chen, the retired librarian who assumed her lack of energy was just the price of aging, her new physician left her core diagnosis untouched. Instead, he simply adjusted her therapeutic class and lowered her daily dose. Within 3 weeks, her persistent lightheadedness vanished, and her natural energy levels returned. She joyfully told her family that she felt as though she had been granted years of her life back. Today, Margaret's blood pressure remains safely managed, but the metrics on the clinic screen finally align with a life she can actually enjoy living. Always remember, a blood pressure prescription should exist to improve your daily life, not just extend your timeline. If a daily pill successfully regulates a digital number but systematically drains your physical energy, your balance, your mental clarity, and your daily confidence, that isn't true healthcare. That is an unacceptable compromise. The most effective blood pressure level isn't the lowest one possible. It is the one that allows you to truly live your life.